The knee is a complex joint, which is composed of bones, cartilage, tendons, and ligaments. In the knee, the ends of two bones, the femur on top and the tibia below, are covered by a smooth, firm coating called articular cartilage. The back of the patella, or kneecap, is also covered with this smooth articular cartilage and slides against the front aspect of the femur. This cartilage allows the femur to move smoothly on the tibia, and the kneecap to move smoothly on the front of the femur, or thigh bone, as the knee bends and as the thigh muscle contracts to allow you to carry out activities such as climbing stairs. This cartilage, when healthy, enables you to bend your leg at the knee easily and without pain. Arthritis is the condition where this cartilage wears out, and the joint can no longer move effortlessly and without discomfort. Patients with arthritis often experience pain, especially with activities such as walking, stair climbing, and rising from a seated position. People with arthritis also often have limited motion of the knee and swelling involving the knee joint. The most common form of arthritis is degenerative or osteoarthritis, but trauma to the knee and rheumatoid disease or other types of systemic arthritis may also lead to breakdown of this articular cartilage and degeneration of the joint. A sensation of grinding occurs when the articular cartilage is worn, either partially or completely, which allows one bone to rub against the other and causes pain. Although cartilage cannot be seen on X-ray, you can see how wearing down of cartilage affects the space between the bones. In the first X-ray, note the wide, smooth space between the femur or thigh bone and the tibia or shin bone. The space reflects healthy articular cartilage maintaining a normal joint space. In the second X-ray, note the femur is touching the tibia, which is creating a bone-on-bone condition that occurs when articular cartilage is completely worn away. The third X-ray demonstrates a similar finding behind the kneecap when the cartilage behind the patella is worn, allowing the kneecap to contact the femur in a bone-on-bone manner. Moderation and modification of activity are important for reducing the symptoms of arthritis. For example, you may need to reduce walking, particularly if you do it for exercise, and if walking a lot significantly increases discomfort. You may also have to avoid stairs, and certainly avoid athletic pursuits that can be painful, such as running and court sports. In particular, in the younger active individual, court sports that involve directional change can produce significant discomfort. Many people benefit from the use of heat or ice, applied in a safe manner and taking care to avoid skin damage. Individual preference for heat or ice varies. Many people also benefit from external support or compression, such as a neoprene knee sleeve or elastic bandage around the knee. Along with these methods for reducing discomforts, oral medication can also be of benefit. Over-the-counter medications, that is, medications you don't need a prescription for, are usually used first. These include acetaminophen, ibuprofen, or naproxen. Once over-the-counter medication is not effective in controlling discomfort, you may be given prescription non-steroidal medications. This will require physician evaluation. The use of nutraceuticals such as glucosamine and chondroitin sulfate may also be beneficial in moderate to severe osteoarthritis. In addition to oral medications, injections may be used. Occasionally, cortisone is injected into the arthritic knee to help decrease inflammation and therefore decrease pain. This measure, which can be employed several times a year, is temporary. The degree of relief provided and how long the effect lasts are both unpredictable. In addition to cortisone, a natural protein may be injected into the knee. This treatment involves a series of 3 or 5 injections, which diminish pain for a variable amount of time. The effect usually lasts 2 to 3 months, but may be longer in some people. In general, this treatment can be repeated twice a year. Another option is a surgical procedure known as osteotomy, which shifts the weight from a diseased area to a non-diseased area of the knee. The procedure involves removing a wedge of bone, generally from the upper tibia but sometimes from the distal end of the femur, to realign the lower extremity and move the weight-bearing axis to an area of the knee where the cartilage is normal. Younger, more active patients may be good candidates for osteotomy. Unfortunately, this procedure is unpredictable in terms of duration and degree of pain relief. Many patients who undergo osteotomy will later face knee joint replacement. Occasionally, the arthroscope is helpful in cleaning out the arthritic knee. This procedure is most effective in someone with significant mechanical catching and locking of the knee due to cartilage or meniscal tears in the knee. This procedure is very unpredictable for relieving arthritis pain and is generally not done only for pain relief. Arthritic disease in the knee usually gets progressively worse. Although the X-ray might not show worsening, the patient may experience increasing pain and incapacitation. Your doctor may order other imaging studies, such as an MRI, to look at other structures within the joint. The measures that have been described are designed to allow a person to live with their arthritic natural knee. If these treatment options become ineffective, the next step may be consideration of knee joint replacement. If you and your doctor decide that total knee replacement would be advantageous, you should completely understand the risks and benefits associated with the procedure. An artificial knee joint replaces your natural knee joint with one made of metal and plastic. The goal is to relieve pain and improve motion and function. Artificial joints can be very successful in achieving these goals. The question patients most frequently ask is, how long will the replacement last? The duration of an implant varies, depending on your age, activity level, and many other factors. The more demand that is placed on the artificial joint, the greater the potential for wear and failure over time. With your new knee joint replacement, it is okay to walk, bike, golf, and even play doubles tennis. Ultimately, someone who chooses to undergo knee joint replacement will have to accept some limits in physical activity. It is important to talk to your surgeon about your desires and anticipated demands before considering this procedure. Before your surgery, you will spend ample time with your doctor and his or her staff learning about normal and arthritic knee anatomy and discussing your specific knee problems. Your doctor will thoroughly examine your knee and will offer you adequate time to ask questions about the surgical procedure, rehabilitation options, recovery time, and special needs you may have before and after surgery. It is important that you address any concerns you might have with your doctors before knee replacement. Preparing for total knee replacement begins weeks before the actual surgery date. In general, your doctor may discuss the following with you. Autologous blood donation. While some total joint procedures do not require a blood transfusion, it is possible that you may need blood during or after surgery. You can donate your own blood before surgery. Dental examination. Dental procedures such as extractions and periodontal work should be completed before knee replacement surgery to reduce the potential for infection. Medications. Your doctor can advise you which over-the-counter and prescription medications should not be taken before surgery. Stop smoking to help reduce the risk of postoperative lung problems and improve healing. Lose weight. In patients who are overweight, losing weight will help reduce stress on the new joint. Laboratory tests. Blood test, urine test, an EKG or cardiogram, and chest X-ray may be prescribed to confirm that you are fit for surgery. It is important to be in the best possible overall health to help promote the best possible surgical experience. Increasing upper body strength is important because of the need to use a walker or crutches after knee replacement. Strengthening the lower body is also key because increasing leg strength before surgery may reduce recovery time. Here are some exercises that your doctor may recommend to help speed your recovery. Low-impact aerobic exercise. Swimming and riding a stationary bike are great low-impact exercises that help build strength in your knee. Stop any exercise that causes increasing pain. Short arc knee extensions. Roll up several towels in a roll 6 to 8 inches thick. Lay in bed with the towels under one knee. Bend the other knee. Keeping your knee on the towels, lift your foot to straighten the knee. Hold for a few seconds and lower the foot. Ankle pumps. While lying in bed, point your toes downward and then bring your toes back up towards your head, tightening your calf. Heel slides. Slide your heel along the bed, pulling your foot towards you as your knee bends. Straight leg raise. Start by tightening your quadriceps, the muscles in the front of your thigh. Then, with toes toward the ceiling, lift your leg 6 to 12 inches from the bed. Quadriceps sets. Lie on your back, legs straight. Tighten the muscle in the front of your thigh as you press the back of your knee toward the bed. Hold for a few seconds, then relax the leg. Standing knee bends. Stand while holding on to a steady surface, such as a table. Bend your knee as far as it will go comfortably. Hold for a few seconds and lower the leg. Increasing upper body strength is also important because of the need to use a walker or crutches after knee replacement. Bicep curls. In a sitting position, keep your elbow close to your body and your wrists straight. Bend your arm, moving your hand up to your shoulder, then lower slowly. Triceps extensions. Sit, leaning forward from the waist. Bend your elbow so that your forearm is parallel to the floor. Then straighten your elbow as you extend your arm behind you. Seated press-ups. Sit in a sturdy chair with armrests. With palms on the armrests, press down to lift yourself from the chair. Hold for 3 to 5 seconds. Bend your elbows slowly to ease back down. Talk to your doctor before starting any exercise program, and remember to call your doctor if you experience increased pain or swelling in your knee after exercise. The great majority of total knee surgeries are complication-free and result in significant pain relief and restoration of mobility. However, as with any surgical procedure, there are defined inherent risks that you should be aware of. Medical risks of knee replacement surgery include infection, which may occur in the days or weeks after surgery. Infection can also occur at any time during the life of the artificial knee if bacteria migrate to the joint through the bloodstream from another part of the body. It is recommended that you take preventive antibiotics after your operation for routine procedures such as dental work. Your doctor will let you know how long you will need to keep taking them. Other medical risks of knee replacement surgery include blood clots involving the leg or lungs, complications from anesthesia, nerve or blood vessel injury to surrounding tissues, failure or delay of wound healing with loss of skin. A knee with multiple scars and previous operations is particularly at risk. Postoperative bleeding, possibly requiring blood transfusion, heart attack, stroke. Other problems may occur with the implanted joint itself over the life of the patient or lifetime of the implant. Although infrequent, these problems can occur and include loosening of the knee implant where it is fixed to bone, breaking or wearing out of the implant itself, problems with the kneecap or patella, including dislocation or fracture and/or failure of that implant, swelling and continued pain and stiffness. It is important for anyone planning on a knee joint replacement to understand that an artificial knee is not a natural knee. Some people may not be able to squat or kneel as easily or as fully as they'd like. Also, your surgeon may not recommend that you do so. A person's legs may no longer be the same length after one-sided knee joint replacement, especially if there was a significant deformity before surgery, such as bow legs. Before, during, and after surgery, your doctors and other medical professionals will take many steps to avoid any complications, performing various tests to ensure you can safely tolerate surgery. For example, you will be given a medication to thin your blood. This medication, either in oral or injectable form, helps reduce the risk of a blood clot. You may need to take this medication for up to 2 or 3 weeks after the surgery. After your surgery, you may also have devices that compress your legs or feet to further reduce the risk of blood clot. During and after your surgery, you will be given several doses of antibiotics to reduce the risk of infection. To begin the surgery, your doctor will make an incision on the front of your knee, cutting through the tissue surrounding the muscles and bone. The kneecap, or patella, is rotated to the outside of the knee to help your doctor see the area where the implant will be placed. With the end of the thigh bone, or femur, now exposed, your doctor will use special cutting instruments to measure and make precise cuts of the bone. The end of the femur is cut into a shape that matches the corresponding surface of the metal femoral component. This component is then attached to the prepared end of the femur. Next, the shin bone, or tibia, is prepared with a flat cut on the top. The exposed end of the bone is sized to fit the metal and plastic tibial components. The metal component is then inserted into the bone. A plastic insert, or bearing surface, is then snapped into the tibial component. The femoral component will slide on this plastic as you bend your knee. If needed, the kneecap or patella is also cut flat and fitted with a plastic patellar component. Your surgeon may choose to use cement to help fix the implants on your bone. Your doctor will conduct several tests during the surgery to ensure the correct sized components are used to help you regain good balance and motion in your knee. Your doctor will rinse out the debris from your knee with sterile fluid and then close the wound in layers with stitches and/or staples. A plastic drain may be placed in your knee to remove blood from the inside of the joint that can accumulate after surgery. The plastic drain will eventually be removed. When you awaken from surgery, you will be in the recovery room. Pain management after surgery is an important part of your operation and often one of the greatest concerns for patients. Your doctor will have talked to you about this before your operation. Pain management after surgery may be achieved by a variety of techniques, including various types of spinal anesthesia, nerve blocks, patient-controlled injection of medication into their IV, and oral medication. After surgery, you may be fitted with a CPM, or Continuous Passive Motion Machine. This device will automatically flex your knee while you are resting. Your surgeon will let you know whether you will be using this device, how much, and for how long. In the days following surgery, your condition and progress will continue to be closely monitored by your orthopedic surgeon, nurses, and physical therapists. Much time will be given to exercising the new joint, as well as deep breathing exercises to prevent lung congestion. Gradually, pain medication will be reduced, the IV will be removed, diet will progress to solid food, and you will become increasingly mobile. Rehabilitation is an important part of your recovery. After surgery, your physical therapist will show you how to get out of bed properly and begin walking with your walker or crutches. It's important to know that your pain can be managed so you can effectively complete your post-op exercises. You will start post-operative therapy almost immediately, gradually moving from passive to active exercises, which will strengthen your knee. Your physical therapist will work with you on post-operative exercises, many of which will be the same as the pre-operative exercises in this program. Your physical therapist will also teach you how to safely negotiate stairs and how to get into and out of a car during the first few weeks after surgery. You'll be in the hospital 3 to 4 days. This may vary based on your progress. Your doctor and physical therapist will establish discharge goals, and once these goals are met, you will be discharged. Rehabilitation will continue either at your home, an outpatient facility, or in a rehabilitation facility. A word about airport security. Since your implant is made of metal, it will almost always set off the metal detector at airport security. In this era of heightened surveillance, almost all security checks no longer accept a document that states that you have a metal implant in place. You should inform the screener that you have an artificial knee. Be prepared to be evaluated with a handheld detector. It is useful to wear loose-fitting clothing so that you can show your knee to the inspector if necessary.
Hopefully, this educational information has provided for you a more complete understanding of your knee problem, as well as options for its management. Replacement surgery is done hundreds of thousands of times per year in the United States and is among the most predictable and successful of all operations in terms of decreasing pain and improving quality of life. But like all surgery, it is associated with inherent potential risks and complications. We have tried to describe these as well as the actual procedure in a manner that will help you when considering this procedure. As always, please discuss any questions or concerns with us. Thank you.